All right, let's dive straight into a high-yield board review focused on managing scalp seborrheic dermatitis. In this explainer, we are going to stick strictly to the essential board-relevant information from the latest international expert consensus. No fluff, just the facts you need to know. Let's get right to it. Here's our game plan. We've broken this down into 5 key modules. We'll kick things off with the basic definition and biology, then get into the weeds of diagnosis and grading. After that, we'll do a really deep dive into first-line treatments before we tackle the advanced options for those tough, severe cases. Okay, first things first, we have to build a solid foundation. To really understand how to treat this thing, we've got to know exactly what's going on at the microscopic level. So what exactly is scalp seborrheic dermatitis? The key words to lock in your brain are chronic and relapsing. This isn't a one-and-done condition. Clinically, you're looking for a classic triad: erythema, which is that redness, greasy, yellowish flakes from the scaling, and very often pruritus, or itching. Remember those 3 for any clinical vignette you might see. Now, this is where things get really interesting. For a long time, we thought this was all about an overgrowth of Malassezia yeast. But it turns out that's not the whole story. It's actually a much broader problem, a dysbiosis of the entire scalp microbiome. Yes, you see more Malassezia, especially M. globosa and restricta, but you also see an increase in Staphylococcus, particularly S. aureus. And, just as importantly, you see a decrease in the good guys, the protective Cutibacterium species. It's the whole ecosystem that's out of whack. And this slide shows you exactly how that microbial imbalance leads to what we see in the clinic. Think of it as a domino effect. First, the Malassezia enzymes start breaking down your natural sebum into these irritating unsaturated fatty acids. Step 2, those fatty acids cause inflammation and poke holes in the skin barrier. Step 3, the body tries to fix that damaged barrier by overproducing skin cells. That's the hyperproliferation and scaling you see. And finally, this whole messed up environment, now with a higher pH, becomes the perfect breeding ground for S. aureus, which just makes the dysbiosis even worse. So, now that we understand the why behind the disease, let's talk about the what it actually looks like in a patient. This brings us to diagnosis and severity grading, which is absolutely critical because it's going to dictate our entire treatment plan. Okay, this table is pure gold for your exam, so let's break it down. The grading criteria are super clear. For mild disease, you're thinking small scales and either no erythema or a very small patch. For moderate, things ramp up. The scales are more prominent, the erythema is bigger, specifically between 2 and 5 square centimeters, and the itching becomes frequent, but it's not so bad that it keeps them up at night. Now, for severe disease, these are the details you have to memorize. We're talking thick, diffuse, yellowish scales, erythema that's greater than or equal to 5 square centimeters, and the pruritus is so bad it does affect their rest. Also, look for 2 other key signs: a strong burning sensation and that classic finding of a ton of scales falling onto their clothes. Distinguishing SSD from its lookalikes is a classic board question, so let's run through the key differentiators. Soraya says you're looking for sharply defined plaques with silvery white scales, not the greasy yellow ones of SSD. On dermoscopy, the buzzwords are red dots, globules, and twisted red loops. Tinea capitis? The biggest clue is usually the patient's age. It's much more common in kids, and a trichoscopy will show you fungal invasion of the hair shaft itself. Contact dermatitis is all about the history. You're looking for a clear link between their flare-ups and exposure to something specific. And finally, don't forget about FAPD, fibrosing alopecia in a pattern distribution. This is a scarring alopecia, and you'll see follicular miniaturization and fibrosis, which you don't see in classic SSD. All right, time for the main event. First-line therapy. This is where we take everything we just learned about the why and the what and turn it into a concrete treatment plan for our patients with mild to moderate disease. The first-line algorithm is actually pretty straightforward, and it all hinges on that severity grading we just did. For mild disease, it's simple monotherapy with the topical antifungal. Think shampoos, solutions, or gels. The regimen is 3 times a week for 4 weeks. For moderate disease, we need a 2-pronged attack. We keep the antifungal regimen, but we add a daily topical corticosteroid, specifically betamethasone valerate, for up to 4 weeks to get that inflammation under control fast. Okay, mechanism of action. You know this is prime material for an exam question. Let's look at the 2 level A recommended antifungals. Ketoconazole is an imidazole. It works by blocking an enzyme called lanosterol C14 demethylase. By blocking that enzyme, it stops the fungus from making ergosterol, which is absolutely essential for building its cell membrane. No ergosterol, no fungus. Cyclopyroxolamine works differently. It's a hydroxypyridone that messes with the fungus's metal-dependent enzymes, causing damage to its mitochondria and cell membranes. But here's the extra pearl for cyclopyrex. It's also anti-inflammatory because it inhibits prostaglandins and leukotrienes. Let's get into the nitty-gritty for ketoconazole. For the shampoo, at 1 to 2%, the treatment dose is twice weekly for 4 weeks. A key finding to remember is that once-weekly use is effective for maintenance to prevent relapse. The 2% foam is applied twice a day and has a great safety profile, even with use up to a year. And finally, the 2% gel, used twice a week, is your option for fast efficacy and a low rate of recurrence. Now for cyclopyrox. The shampoo comes in 1 to 1.5% strength, and it's used 3 times a week for 4 weeks. Here's a great clinical pearl. Studies have shown there's no significant difference in how well it works, whether you use the higher or lower concentration. The 0.77% gel is used twice a day for 4 weeks and has been proven effective against placebo in studies on moderate to severe cases. So, going back to our patient with moderate disease, why do we add that steroid? It's all about speed. The steroid of choice is betamethasone valerate, and its whole job is to get that inflammation, the redness, the scaling, the itch, under control and fast. But the key word here is acute. This is not a long-term solution, and you have to warn patients about the risk of side effects like skin atrophy with prolonged use. So, what happens when those first-line treatments just don't cut it? Or when a patient walks in the door with severe disease from the get-go? That's when we move on to our advanced and second-line treatments. For severe SSD, we have to get aggressive with a multimodal approach. First line isn't one drug. It's a triple therapy, a topical antifungal, an oral antifungal, and a potent topical corticosteroid, which could even be the super potent clobetasol propionate. Now, if that triple threat doesn't work, we move to our second-line option, low-dose oral isotretinoin, also used alongside a topical corticosteroid. Let's be very specific about the drugs in that first-line combo for severe disease. The topical antifungals are the ones we already know, like ketoconazole and cyclopyrox. The oral antifungals are used off-label, but here's a huge pearl from the expert consensus. They consider itraconazole and fluconazole to be the most effective and safest oral options. And for the topical steroid, you can use gothamesosone valerate, or if you need more firepower, escalate to the more potent clobetasol propionate. When we have to escalate to second-line therapy for those really severe recurrent cases, our go-to is low-dose oral isotretinoin. And yes, you absolutely need to know this dose for your exam. It's 0.20 to 0.25 milligrams per kilogram per day. This is a powerful drug that we reserve for those truly tough refractory situations. Now, beyond that main algorithm, you should be aware of a few other off-label options that are in the toolbox for difficult cases. Topical calcineurin inhibitors like tacrolimus and pimecrolimus are a great steroid-sparing option. Other oral retinoids might sometimes be considered. And for a really bad, localized flare-up, you could think about intralesional steroids, although that can be painful and not very practical for a diffuse scalp condition. And finally, let's not forget our supporting players. Adjunctive therapies can be used at any severity level to help our main treatments work better. To help physically get rid of that scale, we can use topical keratolytic agents. The big three are salicylic acid, urea, and coal tar. And to help with patient comfort and manage scalp sensitivity, don't underestimate the value of specialized dermocosmetics. So this brings us to a final, thought-provoking question for the future. As our understanding of the scalp microbiome gets more and more sophisticated, do you think we'll see a shift in therapy? Maybe less focus on just killing Malassezia and more on strategies to rebalance the entire microbial ecosystem? It's definitely something to keep an eye on. That wraps up our high-yield review. Thanks for joining us.